Hi, everybody, and welcome to our webinar on connecting the dots across oral health, food insecurity, and malnutrition. I'm Meredith Whitmire. I am the Policy Director for the Defeat Malnutrition Today Coalition. Today's webinar is, as is pretty obvious from the subject, going to be about the connections between oral health, food insecurity, and malnutrition. As you all know, food insecurity and poor oral health contribute to malnutrition and threaten the health, independence, and well-being of older adults. Innovative programs are screening for and addressing oral health problems and developing and delivering modified meals which are appropriate for reduced function. And today you will learn about these programs. Just a little bit of housekeeping before we get started. You can ask your questions throughout, but we will be taking all questions at the end. You can ask your question in the questions panel, which you can see an example of that here. And you should be able to hear everything through either computer audio or through calling in via phone. So today I'd like you to meet our presenters. First, we have Mario Orozco, who is the Principal Investigator at West Health Institute on Oral Health Care. And he brings over 15 years of experience in clinical research, public health, and healthcare administration. He has dedicated over a decade of his career working in community participatory research with a focus in oral health in several community health centers and public schools, serving vulnerable populations in the U.S. and in Costa Rica. Mario is a past president of the Hispanic Dental Association of San Diego. He holds a DDS from the University of Costa Rica, a master's degree in public health from Boston University, and a master's in business administration from the University of San Diego. Next up, we will have Dr. Tim Platts-Mills, who is the Vice Chair of Research in the Department of Emergency Medicine at University of North Carolina at Chapel Hill. And he also works as an emergency physician. For the past decade, he has conducted prospective studies of older adults receiving care in the emergency department, with particular attention to non-medical problems. His research group is the first to formally characterize the scope of the problem of malnutrition and the etiologies of malnutrition among older adults in the emergency department. And finally, we will have Dr. Kavita Ahluwalia, who received both a DDS and MPH from the University of Michigan at Ann Arbor and completed a residency in dental public health from the Veterans Administration in Perry Point, Maryland. She is the director of the college's dental health public health residency program at Columbia University. And her research is focused on the utilization of community-based participatory methods to address oral health and oral health care disparities across the lifespan. In particular, she is interested in working with communities and non-dental professionals to integrate oral health into existing systems of care, both in the United States and in East Africa. So to kick off our webinar, we will start with an introductory word from Bob Loncato, who is the National Coordinator of the Defeat Malnutrition Today Coalition.
Thank you very much, Meredith, and good afternoon and good morning to everyone. The Defeat Malnutrition Today Coalition is especially pleased to be partnering with the West Health Institute for this webinar focused on oral health, malnutrition, and food insecurity. West has been the national leader in promoting and supporting a greater focus on oral health to improving the quality of life for older adults. This includes supporting a first-of-its-kind oral health clinic within a comprehensive senior nutrition center in San Diego, California. West is also an original member of the Defeat Malnutrition Coalition, and we are grateful for their support of this webinar. Research has determined that poor oral health is a contributor to malnutrition among older adults, and up to 1 out of every 2 older adults is at risk of malnutrition, so we must recognize this as an urgent public health issue. Our coalition, with more than 90 members, is the national advocacy voice aimed at raising awareness about malnutrition as a threat to older adult health and working on legislative and regulatory solutions. Our efforts have been enhanced by the specific comments made late last year by Health and Human Services Secretary Azar, who pointed to malnutrition and its $42 billion estimated cost, and also the fact that a plan that includes screening and assessing and treatment can save considerable amount of money on healthcare costs. We are also focusing attention on the pending reauthorization of the Older Americans Act and working to build on a provision from the last reauthorization, which had the first language on oral health for older adults. It would allow the Aging Network to use grant funds to deliver oral health screenings, among other disease prevention and health promotion services, within their existing funding. We need to see how much activity was generated in the Aging Network, and if demand continues to grow, to work to ensure more specific funding for this activity. We look forward to the presentations today, and now let me turn the webinar over to my good friend Brenda Schmidt-Henner, the Senior Director of Successful Aging of the West Health Institute.
Thank you so much, Bob. West Health is pleased to partner with Defeat Malnutrition today on today's webinar. Next slide, please. For those of you who may be unfamiliar with West Health, you might be wondering who we are and why we're interested in malnutrition. West Health is creating and fostering new integrated care models that improve health outcomes and better address both the medical and non-medical needs of seniors and their families. And our institute, policy, and foundation all work together under the umbrella of West Health with a shared mission to slow the trajectory of rising healthcare costs while improving access to and enabling successful aging for our nation's seniors through research, policy, advocacy, and philanthropy. Next slide, please. You all have heard the statistics. Every day, 10,000 people turn 65, and by 2040, 21% of our population will be 65 and older, putting an enormous strain on our healthcare delivery system. You heard Bob talk about the annual burden of disease-associated malnutrition in the U.S. among adults 65 and older. It's estimated to be $51.3 billion. And I think we can make sure that we all understand that as the population of older adults continues to grow, so will the incidence and costs associated with malnutrition. Next slide, please. So West Health, recognizing both the human and the financial toll of malnutrition on older adults, in February of last year, we convened a senior malnutrition visioning session in Washington, D.C., and engaged national leaders in healthcare, aging, senior nutrition, policy, and research to share constructive dialogue and to exchange innovative ideas to advance comprehensive malnutrition care and prevention for seniors through practice innovations and community-based solutions. The output of that session was this multi-year roadmap that was later shared with a broader audience at the 2018 Aging in America Conference in San Francisco. Through improvements in the identification of senior malnutrition and risk for malnutrition, community intervention, evaluation of best practices and research, and advancing policies that provide incentives for quality measurement and reimbursement for malnutrition-related activities, we are confident that the incidence of senior malnutrition can be reduced, thus averting an ever-growing threat to successful aging. Meredith, I'm going to turn the presentation back over to you.
Thank you so much, Brenda, for that introduction. And I'd like to go ahead and introduce our first presenter, Mario Orozco. And I've already read everyone's bios, so Mario, please take it away.
Thank you, Meredith. Thank you, everyone. Today, I'm going to talk to you about oral health and malnutrition and how these conditions are associated. In addition, we will review at the end 3 actions that you can take as a community-based organization, physician, or dentist to improve both conditions. Next slide, please. Serving Seniors Gary and Mary West Wellness Center is a San Diego-based nonprofit organization that provides programs and services to older adults living in poverty. About 5,000 low-income seniors rely on the Wellness Center every year for nutrition, housing, care management, and health and wellness support, including dental care. Next slide, please. Back in 2012, one of our funders, Mary West, she was serving meals at Serving Seniors, and she noticed that some of the older adults were having issues chewing and eating their meals, and she thought that they didn't like the food. At the time, if you look at the slide on the picture, is Karen Becerra, and she's our dental CEO, and she was working at West at a different capacity, but she happened to be there that day, so that was an aha moment. And she was Mary talked to her and said, we need to do something about this. So Mary decided to build a dental clinic within the Wellness Center, and that's where it all started. In addition to receiving comprehensive dental care at the clinic, older adults receive comprehensive geriatric assessments. This is done by a senior care navigator, and what he or she does is they administer the assessment, and then they will find out as to whether or not this person has some medical issues or unmet social needs, and they will connect this person to all the resources that are available at the Wellness Center, or if we don't have those, then we'll refer them out to other organizations in San Diego. I'm going to quote here our Chief Medical Officer, Dr. Zia Aga, who said that each dental visit is an opportunity to make sure prescribed medications are being taken, social problems are being addressed, and nutritious food is being eaten. Next slide, please. So oral health is a state of being free from chronic mouth and facial pain. And we mostly know about infectious diseases such as tooth decay and periodontal disease. But there are other diseases that affect the mouth, and like cancer, for instance, and they affect how we function. So this may affect how we bite, chew, smile, and speak. And of course, this also has an impact on the psychosocial well-being of each individual. Malnutrition is a complex condition that results from not consuming the proper nutrients, and this may lead to a change in body composition and the functional decline as well. And as you can see, both conditions may share certain factors, such as if you have transportation barriers, food insecurity, poverty, social isolation, frailty, etc., then you may be at risk for oral health, suboptimal oral health, or malnutrition as well. There's a strong link between malnutrition and poor oral health. Impaired oral health results in an ability to chew or swallow food. Having missing teeth or gum disease can negatively impact nutritional intake and result in poor nutritional status and increased risk of malnutrition. As you know, being malnourished can negatively affect the mouth, and this could lead to increased risk of gum disease and other health related problems as well. Next slide, please. So given the close association between malnutrition and oral health and the human and financial toll of malnutrition on older adults, ensuring access to dental care and coverage must be an advocacy priority for community-based organizations, dental and medical providers. To reduce the incidence of malnutrition among seniors, we must screen for and address the health and social comorbidities related to poor oral health, like food insecurity in the home and health care settings as well. Next slide, please. Now we're going to dive into some dental statistics to illustrate the current situation that seniors face. Dental coverage is the largest barrier for older adults. About 2/3 of seniors don't have dental benefits, And however, seniors are high utilizers of dental services. You can see that 47% of adults sought out dental services. This is data from 2015. And they are only second to children who are insured at a much higher rates, which is about 90%. The average expense of dental care in a year is about $900. However, out-of-pocket expenses amount to 64%. And this is very high and is higher than other age groups. And this is mostly because, well, they don't have any dental coverage or also they may require more complex and costly treatments. Next slide, please. Now we're going to look at what is the correlation between tooth loss, poverty, and malnutrition risk. Edentulism or toothlessness, is not having any teeth in your mouth, is an indicator of health. And the national median in the United States is about 14%, but it affects disproportional seniors with lower incomes. You can also see on the right-hand side of the slide that the national median for partial edentulism, and I'm talking about prevalence, is about 36%. And it also affects poor seniors the most. Next slide, please. You can see that 1 in 5 seniors have untreated tooth decay, that is active infections in their teeth. And you can see also that 96% of seniors have experienced tooth decay. And this is relevant because of recurrent tooth decay. So if you had a cavity when you were a child or a younger adult, and then you had a filling, there may be recurrent decay, as time goes by. And the problem with this is then as you live longer, then you're more likely to have more restorations and you are likely to require more treatment later on that may be more complex and more costly as well. You can also see that about half of older adults have mild or moderate periodontal disease and 9% have severe periodontal disease. And this is relevant because moderate and severe periodontitis are often linked to various chronic diseases. Next slide, please. And speaking of systemic and chronic conditions, well, there's currently not a causality. We cannot determine that there's a direct link between oral diseases and chronic systemic diseases. We know that there are strong associations. And you can see the list of some of the conditions, and actually the list is longer than this. But the most known ones are diabetes, respiratory infections, malnutrition, cardiovascular disease, and lately they are talking more about associations between oral disease and dementia. And how does this happen? So there are various mechanisms and hypotheses about these mechanisms, but if you have bacteria, so periodontal disease and cavity and tooth decay are caused by bacteria. So if you have bacteria in your mouth, this bacteria can get into the bloodstream and go to other organs or sites in your body. And likewise, the byproducts of this bacteria and the inflammation that can go to other sites of the body as well and may trigger inflammatory responses elsewhere. Next slide, please. So there are some takeaways from the experience that we've had and also from the literature that we have reviewed for a while about studies conducted around the globe. And we understand that the number and the distribution of teeth in the mouth and as to whether or not you have a proper denture will influence what types of foods you eat. So if you have fewer teeth or you have dentures that are in bad condition, you're more likely to eat foods that are not good for you, for instance, fruits and vegetables. And instead, you're going to eat more likely foods that are rich in fats and because you want flavor, and also in carbohydrates. So many of the choices that people make are suboptimal, and this is due to not having good dentitions. And then we also learned that oral health interventions alone are not sufficient. So you can fix somebody's mouth, but if you don't work together with a physician, a dietitian, or a counselor, you cannot change those bad habits. So this is important because you need to work The dentists need to work with physicians and dietitians, as well as other workers need to work with dentists as well in order to make this impact. Next slide, please. So these are the three things that we can do to change this. First of all, now you're listening to us today, so you are wiser today, and you can educate your colleagues and your patients and clients about the connection between malnutrition and oral health. You can, and there are several resources. You can go to the National Council on Aging, or you can go to Defeat Malnutrition Today and find infographics and other materials there. You can also include a screening for malnutrition and oral health in your practice. There are short item screening tools. There is a rapid oral health screening assessment, also the GOHIDE, the General Oral Health Assessment Index. And there's a simple one. Even if you're not a dentist, you can look at a person and they can talk to you. You can notice as to whether or not they're missing teeth or their dentures may not be working well. And you can ask them, do you have any difficulties chewing or swallowing? And the third one is connect your patients with resources in your community. We have supplemental nutrition assistance programs. We have senior farmers markets and other resources. Next slide, please. Here, you will see a link. And this is, you can visit our blog where you can find more in-depth information about what we talked today and about our work and a list of resources to combat malnutrition and oral health among seniors. Next slide, please. There's a video about Mike's story. This video illustrates the work done at serving seniors in dental clinic, and it illustrates how we can address oral health and impact malnutrition as well. Thank you.
And there was no way I could get any help. I can eat eggs, you know. I can eat. I drink a lot of water and applesauce, cottage cheese, peanut butter and jelly. I eat a lot of. I can afford it. Just anything that's soft. Yogurt. I eat a lot of yogurts. They couldn't keep up with the cavities I was getting from the dry mouth. And I had no money. He had to pull over 23 teeth all at once. Some of them weren't ready to come out. Yeah, these are the teeth, but the little pieces. It was a nightmare. I still remember it. I just, you know, God, I don't know if I ever want to go back to a dentist again, you know. When I went down to the clinic, they're really nice there. I have hope that I can get in this tunnel and see the light.
Mr. Higgins.
Yeah, that's me.
How you doing over there?
Oh,
We do this all the time. All right, everything looks good.
Oh my God, that's awesome.
Yeah.
I have really good feelings about this place.
All right, nice meeting you.
Oh, what a beautiful person, man. Really. God, there's some good people here. You know, it would really be nice to be able to eat again like a normal person. And a set of teeth would be a bonus. You know? That would be a bonus. And now we're going to see what happens. It's going to be an adventure.
Hi, good morning. How are you? This is a big day today.
Flowers.
Oh, you didn't have to do that.
I know, but
That's why, as a prosthodontist, I said, I'm going to do the best I can for you so that you don't have that kind of pain. Clean everything off, and I think we're at a good stopping point with
Okay.
your teeth.
I can actually eat like normal people. I'll be able to eat an apple or strawberries.
And you, wow, it's awesome. I mean, where else? I don't know what to say. And I can smile now. Before I couldn't smile because I didn't have any teeth. I was embarrassed. Now I don't have to be embarrassed because I do have teeth. I have something to smile about, you know?
All right. Mario, anything else?
No, thank you. If you have any questions, I'll happy to answer those at the end.
All right. Thank you. All right. Next up, we have Dr. Tim Platts-Mills from University of North Carolina at Chapel Hill. And Tim, please go ahead.
Thanks, Meredith. I'd like to start by thanking the West Health and Defeat Malnutrition today for their attention to the subject, and thank Dr. Roscoe for his great presentation. And I'll add that I have visited the Senior Dental Center in San Diego, and I am so envious that they have that, and I wish that we had that in Chapel Hill, North Carolina as well. Next slide. So I'd like to talk a little bit about my prior work in this area and ongoing work. First of all, I'd like to make the point that the emergency department is an important clinical setting for identifying the problem of malnutrition and poor oral health. As you can imagine, the emergency department takes care of sort of anybody and everybody, but particularly we take care of people who have limited resources and limited access to primary care. Additionally, screening for chronic health problems or otherwise unrecognized conditions is already commonly practiced in the emergency department. So screening for oral health is something that we think we can do in EDs nationally. And then because EDs, there's a sort of standardized culture of care and fairly consistent practice, we do think it's a system where you can sort of implement and scale broadly. And then additionally, an additional advantage of the emergency department is that many emergency departments now have case managers or social workers working there who can help patients link to resources if a problem is identified. Next slide, please. So our first study we did on the subject of malnutrition was in 2015, and we did a single center study just at the emergency department in UNC. We care for a very broad mix of patients based on socioeconomic status and also mixed rural and urban population. We used a standard malnutrition tool called the MNASF. That's a measure of malnutrition. And we found 16% of patients were malnourished, which was surprisingly high to me, but perhaps not so surprising now that you've seen, as for people on this call who have seen the additional data. The risk factors that were identified include financial limitations, essentially poverty, so difficulty buying groceries, but then also difficulty eating due to problems with dentures, dental pain, and difficulty swallowing. Next slide, please. In 2007, because there was a lot of attention given to this original work, this initial work, the 2015 work, we decided to repeat the study. We joined forces with partners in other parts of the country and did 3 emergency departments, and we used the same tool again. And curiously, in our UNC emergency department, we got the exact same number. So 16% of patients, again, were malnourished, which gave me a lot of confidence that that is actually a very accurate estimate. At the other sites, there were some lower numbers. So overall, in the 3 groups, the combined average was 12%. Still about half of patients. Additionally, the combination of malnourished and at risk was about half of patients. And then what we did additionally is we started to look at causes. And so you can't get a definitive sense of cause without doing randomized trials. But through this observational work, we could get a sense of both what the prevalence of the problems were and also how much these problems were associated with the condition of malnutrition. And we were able to calculate something called the population principal risk proportion, which is sort of how much the condition adds to the burden of the problem within the population. And the PARP for poor oral health was over 50%. So that's very high. The next highest thing was food insecurity. And so those were kind of two major risk factors. Next slide. And additional findings from that study, we sort of did some additional in-depth stuff, and which I think is very interesting. So almost 20% of people said reported trouble biting or chewing food. They reported limited kind or amount of food due to dental problems, difficulty accessing dental care, reported self-consciousness about problems with teeth or gums, uncomfortable eating in front of others due to dental problems, and teeth or gum sensitive. So all these variety of problems that patients are facing related to their teeth and related to eating. And then patients, a third of them said they had not had a dental visit in the last 2 years, and 18% had said no dental visit in the last 5 years. And it's, as Mario showed just earlier, more than half of older adults do not have dental coverage. So all of those things sort of are overlapping, concerning problems. Next slide, please. Building on some of the work we've done in West Health's commitment to addressing malnutrition, we are partnering now with West Health to explore a process by which we will screen for malnutrition and food insecurity in the emergency department and link patients to resources. We've done our phase 1 work for this study, and we found that using a slightly different tool, we found a third of patients were at risk for malnutrition. 16% had food insecurity, and then 5% had both. Next slide, please. And so, and then what we're going to do is, so we're going to screen for malnutrition and food insecurity, and then we're going to link to an area agency on aging, and that organization will connect patients to community-based services. And amongst the people who you can see, amongst people who in the third column who both had food insecurity and malnutrition, you can see that 83% of them reported a desire, were receptive to a service, and reported a desire for a service. None of these services directly address the problem of poor oral health, and I think that goes back to the point that Dr. Orozco made about advocacy. Is it's really important to increase funding for oral health for seniors. That said, we will be able to link patients to food services and some other services that may help them with their malnutrition. Next slide, please. So in terms of like where we're going with this is one of the things we are hoping to do is link people who don't have enough food in their home to food. And as you roughly speaking or broadly speaking, food is relatively inexpensive in the United States, although for people who are in poverty, it's expensive. For our country, it is a relatively inexpensive intervention to make sure everybody's well fed. And I think there's a moral imperative there as well. And so we're excited about the opportunity to link people to resources in the community that can help them with that. Dental care, as you know, is more expensive, but it is so important because of both because of the implications for malnutrition and because of the implications for other aspects of physical and mental health and sort of social well-being. And then the other thing I want to mention is the shift to value-based care. I think I have a separate slide. Next slide on this. Next slide, please. So as you may or may not be aware, the United States, the funding for healthcare has predominantly been fee-for-service, as in the healthcare providers get paid for doing stuff. And there is now a pretty rapid shift, particularly in North Carolina, but nationally, towards value-based or population-based care, where insurers will be paid to look after a population, and there'll be a lot more emphasis on trying to improve value for patients and without doing it in a very expensive way. It is overall, it's an essential change, and I think it will create a lot of opportunities for interventions like the Senior Dental Center and like the project we're doing with West Health, where we're going to screen for malnutrition and link patients to services, because those interventions are essentially very high value. They will help patients a lot and not be very expensive. So I did want to make that point. Next slide, please. And then, so in summary, I'm particularly interested in the emergency department. I think it's important to recognize the emergency department and perhaps other settings where people who don't have resources are linking to healthcare, and the emergency department is an important one. But there are other primary care centers, or as West Health noticed, that if you open up a food pantry or a place where people can come and get food, that also is a place where you can identify patients who have additional needs. Oral health and food insecurity, important contributors to malnutrition in this population. And we think that screening in the emergency department linked to services can be an effective way to address the problem. But however it goes forward, it's going to be through partnerships with health systems and insurers. To really do it nationally, there's going to have to be some financial incentives behind it, which we think that there will be in the coming years. So thanks very much. Next slide.
Thank you so much. Thank you. We are going to move to our final presenter, Dr. Kavita Ahluwalia. And Doctor, please take it away.
Okay, thank you so much, Meredith. I just wanted to, before I begin, I just want to acknowledge some of our partners here in New York City, City Meals on Wheels, the New York City Department for the Aging, Dr. Kerry Reed at Weill Cornell, who heads up the Translational Research Institute for Pain in Later Life, and the Bronfenbrenner Center at Cornell University. Next slide, please. So as today's other two panelists have spoken with you already, nutrition is important for successful aging and a central feature of many of the aging programs at the local and federal level. Next slide, please. However, what is often neglected is the role that the mouth plays in nutrition. As has already been discussed, the mouth is central to eating and therefore is also vital to successful aging. You need your teeth to eat, to chew and break down the food. The salivary glands help moisten the food, aiding in swallowing. You need your facial and oral muscles to help with swallowing, and taste buds are important to enjoying the food. We in New York City decided to work with the home-delivered meal population because the home-delivered meal system represents an existing system that addresses nutrition, and we felt that through this system we might be able to address the mouth. Also, just bearing in mind that much of the morbidity associated with oral diseases can be mitigated through daily self-care, and we were interested in learning to see whether the home-delivered meal system could assist in delivering advice about taking care of the mouth. Next slide, please. So in New York City, the home-delivered meal system is administered by the Department for the Aging, and it contracts with 33 agencies across the city's 5 boroughs. City Meals, which is our primary community partner, provides weekend and holiday meals to all of the city's recipients across all the boroughs, and it receives administrative funding from the Department for the Aging, but funds meals through private donations. We chose to work with City Meals because City Meals is connected with all meal recipients, and also because it is very closely connected with all nutrition providers as well as the Department for the Aging. Next slide, please. We had 4 primary goals for this work, but we were very careful in wanting to use a community participatory model because we wanted to make sure that whatever we did was relevant and sustainable. In other words, the community was an equal partner and was at the table from the get-go. So the first thing that we wanted to do was to convene a community advisory board of New York City stakeholders, and we expected them to provide direction and leadership. We had 7 individuals that met every 4 weeks and more often as needed. They also vetted our final interventions and supported us through everything, as you'll see. We also then wanted to find out what the needs, the oral health needs were in a sample of meal recipients. So we did a telephone interview with 300 participants. Because we were working with city meals, we were able to select participants across the city and have representation from all 5 boroughs. We did some focus groups and key informant interviews, as well as informal meetings to learn the structure and the system, and also to understand where there were gaps, what the resources were. I did a lot of meal deliveries because I really wanted to get a feel for what was going on. And then we took all the information that we gathered and the relationships that we had built to prioritize and inform the development of some interventions. Next slide, please. So just wanted to share with you very quickly some of the data that we collected through the phone interviews. So this was a telephone survey, and I want you to please bear in mind that these are data that represent people who agreed to participate, who had a telephone, could speak English, could hear over the phone, and had a certain level of cognitive function so that they could provide informed consent. So I think that the problem is actually bigger than what this data represent. As you can see, about 15% had Medicaid, and in New York, Medicaid will pay for adult dental services, but 40% said that they had dental insurance either through a private provider or through a Medicare Advantage plan. Similar to the other data that have been presented today, about 45% had not had a dental visit in the past year, and the time since last dental visit was just about 3 years. Of the people who had had a dental visit in the past year, 63% of those visits were for emergency care. And the primary reasons for not seeing a dentist were cost. Next slide, please. When we looked at oral health status, we found that about 26% said that they had no teeth. This is a little higher than we had expected, and 14% said that they had some pain in the mouth. About 35% said that they had dentures that don't fit well or that were uncomfortable. Close to 40% told us that they have difficulty eating some foods, and an equal number were saying that they were avoiding some foods. Next slide, please. Our focus groups and key informant interviews indicated that case managers and other stakeholders all are aware that the mouth is important and actually do try to do some things. They are trying to be proactive. Many of them buy blenders for their clients at their own cost. Many times they advise them to recook the food, but there is nothing that is happening systematically. The system itself is not addressing oral health. The case managers told us that they did understand that the mouth was important, but that they did not have the tools that they needed to link people either to dental services or to get them specialized food. And we were also very aware that this is an overworked provider with many competing priorities. Next slide, please. So we presented the data to our community advisory board and collaboratively came up with a number of interventions for consideration. The first thing we thought was that maybe the system could provide toothbrushes and toothpaste. You know, you get your meal and you get a toothbrush and a little note that says, don't forget to brush after you eat. But in order to do that, we needed to have some way to document who has teeth, who doesn't have teeth, because we did not want to be giving toothpaste to people who had dentures, because we didn't want them to think they could clean their denture with toothpaste. So that led us to, well, we need to really document what's going on. And in order to do that, then we would have to train our case managers. We also thought it would be important to link people to dental providers, because if we were going to find out that there was a problem, we needed to do something about it. And this required us to develop a directory of resources. And finally, If we did find that someone had a problem, we needed to find a way to give them some advice, and it was out of the scope of practice of a case manager to actually provide verbal advice. We thought about delivery of special textured meals and modified meals, but this was really very complicated at the time, and so we decided this was not an intervention we were going to tackle. Next slide, please. So some of the outcomes from this work were that once the Department for the Aging heard that about 40% of people were saying that they were skipping some or all of the meal, they felt that it was very important for them to become involved in this work and worked with us to develop 6 questions that were included in their assessment tool, the Senior Tracking Analysis and Reporting System. They assess 19,500 clients, so this includes clients who don't receive home-delivered meals in addition to those who do. Because they allowed us now to have new items in their system, we had to train the supervisors. They worked with us to develop the training and also funded the training. On our end, we surveyed 500 New York City dentists, learned what kinds of insurances they accepted, what languages they spoke, how close they were to the public transportation system, whether they were wheelchair accessible, whether they could treat in a wheelchair, and so on. We also secured a very large donation of toothbrushes and toothpaste, and we developed some community outreach materials that we developed in collaboration with our community partners. Next slide, please. So these are the 6 items that were included in the STARS database and that the case managers were trained to use. Next slide, please. And these are some of the toolkit materials that we developed. On the left there, you can see the provider directory. Each of the case management agencies received both a hard copy and electronic copy of the directory, which is stratified by borough as well as by zip code, so that they can search, by language or by zip code, by geographic location, whatever they need to search for. And the toolkit, as you can see, we developed a number of different pamphlets that address a number of different topics. And the reason why we did this was because we know that seniors like to put the information they receive on the refrigerator. And most of the outreach information that's available is sort of a trifold that addresses teeth and soft tissues and dentures all in one. Now, I like to consider that I'm a pretty savvy person, but I often can't figure out how to use those trifolds and where they begin and where they end and how to fold them back. And I also know that a trifold doesn't work on a refrigerator. So we at Columbia University developed the content for each of these pamphlets, and our community partners made sure that the language was appropriate. We then received some funding from the Department of Health to translate all these materials into New York City's official languages. So we have them in 6 different languages. And the intent was that a caseworker could walk into a home, realize that somebody has teeth as well as a denture, and give them each of the pamphlets that pertain to their particular need. So, and if somebody had no teeth and perhaps a denture, they would receive the denture care one and perhaps the oral cancer one. Next slide, please. We learned from this work that it's vitally important that the community is at the table and that, the community's voice is heard. Their needs are important. They're the keepers of very important information. They provide context, understanding, and unless they're actually working with you, it's hard to find a solution that can be sustained and that is relevant. Next slide, please. And just as has been mentioned today, before, I think that if we are to do this work and to really make a difference, we need a multidisciplinary approach. We need our community, we need policymakers, dentists, non-dentists, social workers, everybody really to come together and to think about the mouth, begin to normalize the importance of the mouth in aging, in eating, in nutrition. and also to start to advocate for more services. I think we really need to find a way to document the oral health needs, because unless we can shine a light on the problem, I don't think we're going to be able to find a lot of funding to do this work in a comprehensive way and in the way that it needs to happen. I think, therefore, that we all need to be more vigilant about oral health and healthcare among older adults. And I'm just really excited that so many of you are listening to this webinar, and want to thank you for all the work that you do and for being here this afternoon for me, this morning for many of you. Thank you.
Thank you so much. I'm going to unmute our presenters, and I'm going to start looking at questions. I know there have been quite a few submitted, and we may not have time for all of them, but there's a lot. But keep them coming. One presentation question is, will these slides be available? Yes, they will be on the Defeat Malnutrition Today website in PDF form, and we will also have a recording available. And this is a great question. In addition to financial incentives, and as we move toward alternative payment models, what is it going to take to get the provider community engaged in addressing the barriers that exist in people's lives outside of the transaction of care that correlate directly with someone's ongoing health?
Hi, this is Brenda Schmidt-Henner from West Health, and clearly I think that we are shifting into value-based care at a rapid pace, and healthcare is looking at social determinants of health and understanding that what really makes us sick is only partially addressed by the healthcare community. And they're looking to community-based organizations, community settings, community care, everything from community dental care to community social supports to really address the population in a more comprehensive whole person way that can really address their full range of needs. So I think that the momentum is there. The opportunities are there through the Chronic Care Act and the CMS call letter for Medicare Advantage plans around supplemental benefits. And I think we're going to see a growing trend of that care coordination and better integration of both financing and care across the continuum.
Yeah, thanks, Brenda. I might just add to that here locally in North Carolina, we have a couple different ways in which value-based care is manifesting. One is a next generation ACO called the Senior Health Alliance. Another thing is Blue Premier, which is being led by Blue Cross Blue Shield. In both cases, I would just, to editorialize, I'll say providers are really slow, and I am a provider. Providers are slow to change. The change that we're going to see is going to be put on us externally by these insurers and by these organizations that are trying to manage populations. And it does feel all top down, but I don't think that's necessarily a bad thing in this case. I mean, we are being told now that we need to be looking at shared determinants of health. We need to be documenting those things. That's more for primary care providers than emergency physicians. But I think we're going to get increasing pressure from payers and healthcare systems partnering with payers to start thinking about these issues more, and they will help us develop pathways. So the providers on their own are not going to come up with this. I mean, some providers who are enlightened are interested in these issues, but it's going to be these external payers who are going to be putting pressure on us to do that.
Great, thank you. Tim, this question is actually for you as well, I believe. Do you only specifically recommend using the MNA for screening of malnutrition and chewing problems in emergency departments? And should this screening only be conducted on those over 65 years of age?
That's a great question. I will say I shop at Lowe's and Home Depot, so I'm not really totally wedded to the MNASF. There are other, I think in the emergency department, the real criteria is that it needs to be short. There's another tool that we've been using, MST, which we sometimes use. And but the key is that it's a couple questions if you're going to look at malnutrition, because if you're asking nursing assistants or nurses or triage nurses to screen for malnutrition, it's got to be brief. So in regard to whether it should be 65 or older, I mean, for a lot of reasons, we've focused on that population, partly because they're at higher risk for a lot of these issues. Second of all, there are some additional resources in the community that are available to those patients. Third, some of the value-based care systems like the Senior Health Alliance is focused on Medicare populations. But I think ultimately, no, there are a lot of dental issues in people younger than 65. And if you really want to provide value and really be cost effective, what you want to do is improve dental hygiene and care earlier on so that people's teeth aren't falling out, in their 60s and 70s. I'm sure there are others on the call who could elaborate on that, but I do think it makes sense to try to address dental issues in younger people and try to stay ahead of that problem.
Thank you. And this one I think is for probably all of you on the panel. What do you all see as the role of the non-dental providers with respect to oral health care? And specifically, what can nurses do?
So I think nurses can do a lot. I think as Tim just mentioned, you can screen for malnutrition, but even more basic to that, you can screen for ability to eat. Are you able to eat? Are you able to swallow? And to think about the fact that some of those problems might start in the mouth and not in the gut. So I really think just asking some very basic questions. Do you have teeth? If you don't have teeth, do you have a denture? If you do have a denture, are you able to eat with your denture? And, just to find out if people are able to eat, if they're able to communicate, those would be some key things that non-dental providers, I think, can do. Depending on the scope of practice of the provider, you may or may not be able to provide verbal advice about how to take care of teeth and dentures, but there are lots of resources out there, where you can give people information and try to link them to dental services. Now, having said that, linking people to services is complicated just because of how expensive it can be and the small number of dentists that might accept public insurance. But I really do think that if we can get people to just brush every day, twice a day, we can mitigate a lot of the problems.
I also think that it's important for a nurse, if you have a patient in front of you, to look at their medical history and detect what are those chronic diseases that are affecting this person. For instance, if you have rheumatoid arthritis, then this person may have difficulty taking care of his or her oral hygiene, or if this person has cognitive issues, dementia, and other conditions that will prevent them from being independent enough to take care of themselves. And then if they are dependent, identify their caregivers and educate them, because often caregivers do not know how to take care of the oral health of the people they're caring for. So I will add that too.
Great, thank you. Well, we are basically out of questions. I think everyone's questions have been addressed, and we are also out of time. So I'd like to thank all of our presenters and point you toward our websites for any further information that you might need. So thank you, everybody, again. And we will be sending out some follow-up information, including the slides and the recording, et cetera, and there should be a certificate automatically included so that you can, if you're a dietitian especially, you can apply for CEUs. So thank you, everybody.